Tachyarrhythmias are a commonly encountered condition in emergency medicine and represent one of the few conditions that you will not often have a lot of time to read about before you have to intervene. As an emergency provider, you need to know how to act rapidly and accurately in order to give your patient the best chance of a good outcome. Your first task in evaluation of the tachycardic patient, as it is for any patient, is to look at the patient's level of consciousness, airway and breathing, circulatory status including blood pressure, and to institute any appropriate immediate interventions. Your second task in caring for a patient with tachycardia is to identify the type of tachycardia. This is a rhythm strip of the most common type of tachycardia, sinus tachycardia. It is critical to distinguish sinus tachycardia from other types of tachycardia, as sinus tachycardia is often the body's compensatory mechanism to a variety of physiologic conditions such as fever, hypovolemia, hypoxia, and acidosis. It is rarely necessary and can be dangerous to attempt to treat a sinus tachycardia. Management of sinus tachycardia should focus on identifying and correcting the underlying cause and not on trying to slow the heart or convert the rhythm. Characteristic features of sinus tachycardia are rate between 100 and 150 in adults and up to 200 in infants, generally regular but with some variation with respiration, a visible P wave for every QRS and usually, but not always, a narrow QRS complex. While vagal maneuvers such as the Valsalva maneuver are rarely needed to diagnose a sinus tachycardia, such maneuvers, if done, may result in transient slowing of the rate with subsequent return to the previous rate. Electrical cardioversion and administration of adenosine are both contraindicated in known sinus tachycardia, but if done in the mistaken belief that the tachycardia is not sinus, they will likewise have only a transient effect on the heart rate and rhythm. In addition to ECG diagnosis, the other important step in identifying sinus tachycardia is to look for a credible cause such as fever, hypoxia, hypovolemia, hyperthyroid conditions, or the effect of medications such as antihistamines or illicit drugs such as amphetamines. If the tachycardia does not have a P wave for every QRS complex, that is, it isn't a simple sinus tachycardia, then you want to determine if you are dealing with a narrow or wide complex rhythm. If the QRS is narrow, then you know that the dysrhythmia originates at or above the AV node, and it is less likely to be an immediate life threat. If it is a wide complex rhythm, then it is either originating in the ventricles or it is aberrant conduction in ventricles that is originating in the atria. Next, take a look at the regularity of the complexes. If the tachycardia is regular, then the signal is generated from a single focus. If it is irregular, that is an indication that the electrical signal initiating depolarization is coming from multiple foci. These multiple foci can be in the atria or ventricles. So let's take a look at a few 12-lead ECGs that illustrate these points. What is the rate and rhythm of this ECG, and is it narrow or wide complex? Pause this video now and generate your response. Okay, what do you think? This is a regular, narrow complex tachycardia, just like the rhythm strip of sinus tachycardia that we looked at earlier, but notice that there are no P waves. At around 200 beats per minute, and knowing that this is an adult, it is too fast to be a sinus rhythm. Therefore, this is a supraventricular tachycardia, and more specifically, it is an AV nodal reentrant tachycardia, the specific form of which is to be determined by an EP evaluation at a later time. Some individuals are subject to recurrent episodes of this arrhythmia, in which the tachycardia may start and stop more or less spontaneously. In these cases, we use the generic term paroxysmal supraventricular tachycardia, or PSVT. How about this ECG? This again is a regular narrow complex tachycardia, and there are no P waves as such. However, there is a distinct sawtooth pattern in lead 2 indicative of atrial flutter. If you march out the rate of the flutter waves, you find it to be nearly 300 per minute. 2-to-1 conduction through the AV node results in a ventricular rate of about 150. In this case, the source of the dysrhythmia is a single focus in one of the atria. How about this ECG? This is another narrow complex rhythm, but notice the irregularity. Note here, and here, The RR interval is quite different, and this is true elsewhere as well. This is atrial fibrillation. Since the rate is greater than 100, we call this AFib with RVR, rapid ventricular response. Here's another 12 lead for you to analyze. What's going on here? This is a worrisome ECG in that it is a wide complex tachycardia. It is regular and the rate is right about 150 beats per minute. Every indication suggests that this is ventricular tachycardia. If someone hands you this ECG while you are sitting at your computer, you are going to want to stop what you're doing and immediately get to the bedside. You will want to know the patient's blood pressure and determine if there are clinical signs of shock. Aggressiveness of treatment, either with medications or electricity, will be determined by the clinical assessment. Take a look at one more ECG. This again is a wide complex tachycardia. I'll tell you that this 65-year-old patient is awake and answering questions appropriately. He is not pale or sweaty, but has a mild pressure feeling in the anterior chest. So what do you think of this ECG? Notice the RR intervals are of different durations again, an irregularly irregular rhythm. What rhythm is defined as irregularly irregular? Even though this is a wide complex rhythm, it is most likely atrial fibrillation with a rapid ventricular response, resulting from either a bundle branch block or some other form of aberrant conduction in the ventricles. If the patient has a history of atrial fibrillation, it makes this diagnosis even more likely. To summarize, here is a relatively simple algorithm we can use to identify most tachycardias. First, we need to determine if the rhythm is sinus tachycardia, and if so, look for and treat the cause. If the rhythm is not sinus, we look at the QRS complexes, wide or narrow, and whether or not the rhythm is regular. By putting together these characteristics, we can usually determine the type of tachycardia we're dealing with. While we have not discussed treatment in this video, the primary consideration in treatment of tachycardias is whether the patient is stable or unstable. Once sinus tachycardia has been excluded, unstable patients with any other type of tachycardia should generally be considered candidates for immediate electrical cardioversion. If time allows, the patient should receive some sedation and the airway precautions and management that goes along with it. More stable patients can be managed with medications to slow the rate or convert the rhythm. We could spend all day going through a variety of different tachycardic scenarios, but this little lesson will give you a good start at recognizing the clinical situations you are most likely to encounter in the emergency department. This is a common, challenging, and interesting area of emergency medical care, and I would encourage you to do some further study and become an expert at recognizing tachyarrhythmias.